Okay, so for our second talk on CNS pharmacology, which is going to be very brief, we will look at antipsychotic medication that you might encounter in the emergency department. Again, we will take a clinical scenario and use it to explore the clinical pharmacology of these drugs, including, where appropriate, their pharmacokinetics. So the story is a 45-year-old psychiatric patient who presents following an overdose of his medication, and we're thinking about the likely clinical features of such an overdose. So what are the antipsychotic drugs? Well, the common antipsychotic drugs that we meet are the phenothiazines and the butyrophenones. Again, you might want to just pause the video and see if you can remember their mechanism of action, their common effects, their side effects, both acute and chronic. They block dopamine D2 receptors, but actually they have a much broader action than this in the CNS. They also block noradrenergic, cholinergic, and histaminergic receptors. And as you can imagine, they have a fair mixture of effects, some of which are desirable and some of which are not. The acute side effects of these drugs would include their effects on the CNS, particularly sedation and respiratory depression. They lower the seizure threshold, so they actually increase the risk of seizures in at-risk patients. And they can cause acute dyskinesia. The cardiovascular system, they produce hypotension and postural hypotension, which can be quite severe. They are associated with various types of tachycardias, and they prolong the QT interval, putting patients at risk of ventricular arrhythmias such as polymorphic ventricular tachycardia. And then they do have other acute side effects, particularly their anticholinergic effects, dry mouth, dry skin, flushing, low-grade fever, but also their CNS anticholinergic effects, particularly acute confusion. They can also cause erectile dysfunction, menstrual irregularity, and weight gain. Chronically, they can have CNS effects, including extrapyramidal effects, such as akathisia and tardive dyskinesia. We're just going to mention two other atypical antipsychotics, risperidone and clozapine, both of which you might come across in the emergency department because patients may be on these chronically. So this is a second generation antipsychotic, and it is a D2 receptor antagonist. It has less long-term side effects than the phenothiazines and butyrophenones, so less tardive dyskinesia, less chronic extrapyramidal effects, and less anticholinergic effects. Clozapine, on the other hand, is a D4 and 5-HT2A receptor antagonist, and it has actually less D2 antagonism. So again, it has less long-term side effects, but it does have other serious side effects such as agranulocytosis, a propensity for causing venous thromboembolism, myocarditis in up to 3% of users, and metabolic effects, insulin resistance, hyperlipidemia, and type 2 diabetes. So, as I said, this was a fairly short talk looking at some of the common antipsychotic agents that we come across. If you have any questions or comments, you can bring it up in class and we'll try to answer it. So we've covered the anti-epileptics in the first talk. This talk focused on the antipsychotics, and in our last talk we will look at antidepressant drugs. Thank you for listening.